Good oral health seminar series. We're thrilled to have you here. I'm Liz Flannery. I'm the Director of Education and Leadership here at AIDPH, the American Institute on Disparities in Public Health. We're thrilled to have you here with us today and to have Dr. Jonathan Norris with us here today presenting. Once you join, we would love for you to be on camera and join us in discussion here today. We're going to go ahead and get started. We want to say a thank you to our partners over the many years of this seminar series. We have this series happening every other month throughout each year, and we have asynchronous recordings of previous seminars available on our Academy from past years. Today, I'm going to give us some housekeeping and an overview, and then we are going to hear again from Dr. Jonathan Norris on minimally invasive dentistry, advancing access through clinical and public health integration. We will, of course, have time for Q&A, and we hope that you will engage. I'm so sorry. We hope you will engage and share in the chat as you have questions throughout the session here today. We are recording this session. We will have the recording available on our Academy afterwards, along with session materials and slides. As you share and ask questions, we ask that you avoid PHI, PAI in this session. We also invite you to please type your email and organization, say hello to your colleagues in the chat. If you have any questions or technical issues, you can shoot a DM to Shayla Stewart, who is here from AIDPH, my colleague. She can support us throughout this call here today. And we'll also raise questions if folks have questions about the presentation as we go through. A quick little bit about AIDPH before we get started. Our mission is to empower our community to eliminate health disparities through research, education, and advocacy. So we're pulling some research into an educational session here today to talk about how we can implement some models that increase access in our communities. We do this because we have a vision of accessible, affordable, and a valuable public health system. Okay. So for the last decade, AIDPH has operated at the intersection of health issues, communities, and systems change. We have a little bit of a new framework that reflects the belief that health disparities emerge where health systems, social drivers, and community experiences intersect. We recognize that issues like oral health, mental health, chronic disease, and women's health are shaped by policy environments, care delivery structures, workforce capacity, and the lived experiences of the communities most affected. So if you see that here, our foundation and focus has always been oral health. You will see these expanded health issue areas because our research really shows the intersection of chronic disease, women's health, mental health, intersecting at oral health access. I mentioned our academy. Our academy is our digital learning space, and it's where you can access our materials. We'll have some instructions for you at the end on how to access your CEU if you are requesting that for this session. That lives on our academy. You can also find past recordings of past rural oral health seminars, along with our other programming. These are our session norms. Again, we invite you to add your name to your Zoom display name and add your personal pronouns if you're so comfortable. Introduce yourself in the chat. We use first names during the seminar series to facilitate equality in the discussion. And we invite discussion, Q&A, and interaction throughout. Our presenter, Dr. Jonathan Norris, does share affiliations with Montshire Dental PC and Equity Dental LLC, but no other disclosures other than that. These are our CEU learning objectives. These are also available in the Academy. And without further ado, I'm going to hand it over to Jonathan Norris, who is a board certified pediatric dentist practicing in Southwest New Hampshire. His practice, excuse me, Montshire Pediatric Dentistry has 11 locations providing services in Massachusetts, Maine, New Hampshire, and Vermont. Since 2017, he has been an advocate of practicing minimally invasive dentistry with a focus on non-surgical intervention and reducing pediatric sedations. Through the medical management of caries, he has resigned from 6 hospitals he previously held operating room privileges at. He is passionate about educating the medical and dental profession on the impact this will have for patients, providers, and practices, which he's going to share with us here today. We are so thankful for his time and expertise. So, Johnny, I will hand it over to you.
Awesome. Thank you so much. Yes. So can you all hear me? Like thumbs up. I see Frank in there. Good to see you. Yeah, I'm Johnny Norris. I'm a board certified pediatric dentist. And I think I'm giving this presentation because I've been accused or described as a public health dentist under the facade of private practice. I've also been accused of an accidental DSO. For those of you that aren't dental professionals, a DSO is a dental service organization. And so typically that's reserved for larger group practices. And because I'm in 4 states, people assume that I'm private equity and venture capital backed. I'm not. I'm all natural. You're looking at it. And so I'm going to be talking to you about minimally invasive dentistry today. This is a topic and subject matter that is very, very dear to my heart. I don't think there's any other way that we can get better outcomes and serve more people other than embracing this sort of philosophy. I also want to thank you all for your flexibility. I know I was originally supposed to give this presentation on Thursday. Out of nowhere, like a month ago, my wife got diagnosed with cancer. And we're like right now, I'm abroad doing experimental therapies, which is deemed by the FDA experimental. But it's ironic because I actually am consistent, if nothing else, in where I want to exhaust minimally invasive care before escalating to more more invasive therapeutics or interventions. And what I mean by this is, just last month I was at Dartmouth, and we have a stage 1 cancer where it seems like it's completely curable. And within a matter of 20 minutes, we went from a lumpectomy to a mastectomy to a double mastectomy to a removal of all of my wife's ovaries, along with chemo and radiation, et cetera. And I was like, wow, like in dentistry, that would be like if you have an E1, E2 lesion and you jump straight to endo and crowns. And so I'm just letting you know that's why I had to kind of pivot and change. And I'm abroad right now, seeking out new therapeutics. That being said, I do think this is the gold standard. I know that it works because I see that it works every single day. There's so much literature supporting the type of practice that and philosophy that I'm going to be talking about today. And, I just feel like the reason I'm here is one of my favorite quotes by Isaac Newton is that if I see further, it's because I'm standing on the shoulders of giants. Literally everything I'm going to be talking to you about today has been known for decades upon decades upon decades. I stumbled across it and I just put it into practice. And I just ran with it and I was quite successful. And so, I actually think that Mark Twain said it the best. And so next, Liz. Mark Twain says to succeed in life, you need 2 things, ignorance and confidence. I'm going to let you guys know that most of you know more about public health dentistry or public health policy or system delivery than I do. And you have lots of reasons why this can't work, I'm sure. And I'm gonna just let you know that I'm confident that the literature works and putting it into practice. It all has proved out and bore out success. And so it was really easy back in the day when I had one practice with 11 patients and people said this couldn't work. It's much harder to just sweep us away and say, oh, this doesn't work now when you're in 4 states and you have 35,000 patients. So I do have vitamin H, and I call that hope. I do have hope that there's a lot of people that want to do the right thing. And once they're exposed to knowing that you can do the right thing, you can help more people and you can disrupt a complete industry and still maintain, status quo. And what I mean by status quo is you can still be profitable, but you can actually help more people. And a lot of the problems and things that you see in your practices or clinics or organizations now I've faced. I know what it's like to face financial budget cuts. I know what it's like to almost bankrupt my family. I know what it's like to not have access issues. I know what it's like to go through any sort of different types of abuses, et cetera, et cetera, et cetera. And so I'm just saying here, I've got solidarity with you, and I'm also letting you know there's a better way. So next. I think we kind of went over this already, but just my disclosure statements. Yeah, so I'm the president of my company, Montshire, and also I'm a managing board member of Equity Dental. That's a group out in Oregon. I'm also a national Canberra board member, as well as I'm the secretary and treasurer for the American Academy of Pediatric Dentistry chapter in New Hampshire, and I'm also the board elect there for the next 2 years. So I'll be the president in the following 2 years. The purpose of this slide is just to let you all know that the way I practice dentistry is not the way I practiced 6 months ago, 9 months ago, 12 months ago. Literally, since I've even been abroad, I've been having meetings with various groups in South Korea for new technologies that we can start integrating into our practices using AI. This is the most exciting time to ever be practicing dentistry. And so I'm just letting you know everything that I'm talking about today, unless otherwise stated, and I will let you know when it's my commentary, it's steeped in literature. Next. So the course description, I think we already went through this, but basically, at our break, I'm curious to see how many dental professionals versus not dental professionals we have. But basically, I'm going to be talking about how to integrate clinical principles of minimally invasive dentistry. The acronym is MID, with population-based strategies to expand access, reduce disease burden, delivery, cost-effective care. I can talk about this ad nauseum. Again, I've got way more slides than I'm going to be able to go through in the 40 minutes that I'm allotted. But I want you to have this information so you can reference, and you'll have my contact information so you can ask me questions. I'm an open book when it comes to these sorts of things. Next. Liz already went through these objectives, so I don't really need to go through these as well.
I think we lost your audio for a second, Johnny. I don't know if you had something.
Can you hear me?
Yes, great. Thank you.
Sorry about that. I'm like I said, I'm abroad and I'm at the whims of the Wi-Fi here. So yeah, so if you don't remember anything else about what I'm going to be talking to you about today, this is how I'm messaging this. I'm in another country.
That's what we said. My mom was very graceful and very patient. We'll go ahead and pull the slides back up and we can go ahead and get started or keep going together.
We'll keep going, and I'll put the afterburners on. But yeah, I was talking about the penicillin moment in dentistry, and we're at that same inflection point because in 2014, silver-diamine fluoride was approved by the FDA. And I'm not saying that silver-diamine fluoride is the panacea and all be all. However, it has kicked off in our collective unconsciousness the understanding that caries is an infection, it's a disease, and it can be managed medically. And so, again, I think that we're at that same exact inflection point. And if we start looking at this disease process with that same lens, we're going to be immensely more successful because we cannot, like we all know this, we can't drill our way out of an infection. Next. And so just real quick, Montshire, like that's the name of the organization that I founded. Vermont is the Mont and the Shire is New Hampshire. It's basically an homage to the area and the population I thought I was going to serve. It's important just for you guys to know that I did 2 residencies. I did one at the Air Force Academy. One of the blessings with the Air Force was that I actually did public health dentistry, and I wasn't incentivized to treat disease just by doing as many fillings because I wasn't reimbursed for doing fillings necessarily. And so I would argue that I could actually give the gold standard of care. I didn't have that slow creep of saying, oh, well, maybe if I did this filling or whatever justification that we may or may not use to do treatment or not do treatment, it wasn't there. And as a new clinician, that really had a profound impact on the way I would actually look at this disease process. I did my pediatric dental residency in Alaska. I went there specifically because I wanted to see the highest disease burden, some of the worst in the world. And I was in the operating room, 2 times a week. And at that time, I set records for the most, clinical operative a resident had ever done. Hundreds of cases of sedations. I can't countless crowns, countless fillings, et cetera, et cetera, et cetera. Moved to New England because I'm from the East Coast. I did exactly what I was trained to do. I got on staff at 6 hospitals, and I had an existential crisis a year later. Basically, I was managing this disease, and I watched kids that were waiting for the operating room. Like the wait list went from 3 months to 6 months to 9 months. I watched kids not be in pain, I watched kids not having abscesses, ending up with abscesses, and I thought there was absolutely no way I can get this under control. And what am I doing? Around that time, I went to a CE event in Burlington, and I learned about the medical management of caries, and I listened to the speaker speak, and I completely thought that he was a charlatan. I was like, I did 2 residencies, dental school. Why have I not heard of this? So it's a Friday, and I went home and I read about 60 articles because silver-diamine fluoride's been around since 1969. Glass ionomer's been around since the 70s. Betadine has been around, in dentistry since the 40s. And I was like, holy smokes, I'm doing this wrong. And I didn't know how to monetize it. I didn't know how to make workflow. I didn't know anything, but I did change my practice overnight after reading those 60 articles. And Monday, I just changed the way I practice. And so started practice in 2018 with 11 patients. We've grown to over 35,000. And, one of the reasons I think that we've grown so quickly is because our slogan is every child is welcome. And, there's very sound principles, and we have a true north as to why we do certain things. And I was that kid growing up. And it was never an excuse for me to say, you know what, I can't see you because we don't have access. We've always found a way to help more kids because that's where the disease burden is the highest. So next, you can see what this plays out is as a private practice, I'm 60% Medicaid. And so I've never turned a kid away because of financial situations. And ironically, when we start these practices, we have a very high, like Portland, Maine, you can see we're about 90% Medicaid. What ends up happening over time is actually the numbers start to drop to about 50%. And it's not because we actually limit our access to children on Medicaid. It's really because people want options and parents want agency. And once they hear about you can manage a disease with least invasive options, they flock and they vote with their feet. Next. The problem you guys already, like, again, I know I lost some time, but basically the problem, and we all know it, is not a lot, there's access issues. Half the kids in the country aren't going to see a dentist this year, and it extends beyond just kids. Adults have a hard time seeing folks. We know that we're heading towards reduced federal funding, and one of the reasons I can't blame dentists really because you may or may not know this, but 70% of your overhead, 70% of a dental practice is overhead. And if reimbursements on average for Medicaid is about 50%, most clinicians are looking at this as an unsolvable solution. Either they have to accept financial losses or outright limit this population. And I'm going to say, I think a premise was swept past us. What if we have to reimagine and reinvent the way that we actually manage this disease, not just surgical? Because if you look through surgical lens, you're going to keep ending up with the problems that we've always seen. Next. So the historical response, it's not like bombastic or outlandish for me to say that it's a surgery first approach. That's what we've been doing. And, Einstein said doing the same thing over and over again, expecting different results is insanity. And that's what we've been doing for over 100 years. It focuses on repair of damage and it can be, very effective. However, as I alluded to in my story, my origin story, basically, I was not getting this disease under control doing surgical means. And I watched all these kids waiting for treatment that were never going to get treatment. Because oftentimes, if you try to do sedation, you can only see maybe 3, 4, 5 kids a day. Or if you do sedation for adults, you only see 3, maybe 1 a day, depending on their disease burden. There's no way we're going to get this under control. And I think that it's we tell ourselves it's a noble lie that sedation doesn't have risks. We know that, there can be adverse outcomes with it. If any of you have actually worked with the pediatric population, oftentimes kids wake up hysterical. We like to tell ourselves they don't remember these sorts of things because we give them drugs that have, retrograde amnesia like a Versed or a midazolam. But I can tell you in experience, I see kids that do have this. And all of a sudden we're creating these children that have hesitancy. On top of it, our parents are coming in where they had bad dental experiences and they projected it onto their kids. And so I guess the question I'm asking is this the only thing that we can offer is just watch and wait? Those that are in the dental profession, that's ultimately what we've said for a very, very long time. And I'm arguing that, well, maybe can we go upstream further instead of waiting until it's downstream and completely decimating, your mouth and having all these like reconstructive needs, maybe we can actually intervene much earlier. Next. And so Deming says, he's the guy that basically helped rebuild, World War II Japan with the car industry and saying, with Honda and Toyota and saying that each system is perfectly designed to give you exactly what you are getting today. Right now, Western medicine and dentistry really is emphasized on end stage of disease. If you go to any dental conference, 80 to 90% of what you're going to see when you go on the exhibition floor is going to be talking about crown systems, implant systems, root canal systems. And although we are technically sound, we can do miraculous things, we never think about that poor soul that had to, on our watch, we watch basically this disease decimate and annihilate their dentition to the point we have to do these really crazy and remarkable things. And I'm not sure if that's actually a victory that we should be hanging our hat on as dental professionals. Next. So when I'm talking about, minimally invasive dentistry and surgical management, it's not a versus, it's a continuum. And what I mean by that is do minimally invasive dentistry and I should back up. I hate labels. I actually think in 15 years, we're not going to be calling this minimally invasive dentistry. We're just going to call it dentistry. But if I call it dentistry now, we're going to be talking past one another. So I have to use that label for the time being. However, what it is just like we call it medicine. Sometimes you use medicine, in medicine, sometimes you use medicine, sometimes you use surgery, sometimes you use radiation, sometimes you use blah, 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 blah. Same thing in dentistry. I think sometimes you're going to use silver diamond fluoride, sometimes you're going to do sealants, sometimes you're going to do fillings, sometimes you're going to do crowns. So that's what I want to say is it's not contention, and I'm not throwing shade, and I'm not demonizing a profession. I think we've been using the best with the best tools that we've had for the time being, but we have more and better tools at our disposal now. Next. So minimally invasive dentistry, I should have defined this early, just so you know, it's basically a philosophy that is really on preventing, detecting, and treating dental disease while preserving as much healthy tooth structure as possible. Next. So key principles of minimally invasive dentistry is early detection of the disease. So like obviously we know that the sooner that you can diagnose the disease, the better the prognosis. Caries risk assessment is basically a treatment plan, like, and it should be tailored to our patients. I'll let you know. The caries risk assessments, I've talked to payers about this. 1% of clinicians actually use a caries risk assessment. And right now we have 3 different CDT codes for it: 601, 602, 603. So low, moderate, high. It's not really great at this point. However, as we get better sensitivity and specificity with various diagnostic tools, whether it's AI, whether it's QLF, quantified light fluorescence, whether it's basically fluorescent dye, et cetera, I think we're actually going to develop actually much better protocols, and these caries risk assessments developed specifically for our patients. Remineralization and prevention. So yeah, an ounce of prevention is worth a pound of cure. Up until a certain point, you absolutely can reverse cavities. And if you can, you should, because I have a philosophical belief that nothing I put in a patient's mouth is better than the tooth they were born with. We all know that using operative, once you touch a handpiece and a dental burr to a tooth, it's never the same, and it puts it on a slow death of the tooth. And you can see the statistics on this, but on average, once a tooth has been drilled on, it will slowly die with a long enough timeline, and it will cost $8,000 during the duration of that time. So the concept I'm talking about is trying not to use a dental burr unless I have to, but sometimes I have to. The disease is already there and I have to use it. So to be clear, we do comprehensive care. But ultimately, we want to do stabilization or arrest as much as possible. Next. The goals, I already talked about preserving natural tooth structure. We also want to reduce patient discomfort and anxiety. I see children, and if you want to see a kid lose their mind as quickly as possible, try giving them a palatal shot that's on the roof of their mouth, a shot. Basically, all of a sudden, they're completely unhinged, and now trying to do operative dentistry. Absolutely horrible. That's why you have to put the kid to sleep, because it's trying to paint the Mona Lisa going 60 miles an hour. Completely impossible situation. So all of a sudden we have to put kids to sleep to do the traditional dentistry. Absolutely, you're going to have lower treatment costs for this. I can let you know we are a second opinion clinic. Oftentimes I see patients that have gotten a $10,000 treatment plan that includes the sedation. And we've done it for hundreds of dollars. And I'm not saying it's right or wrong. However, I do have a bias in that I want to exhaust least invasive options first. And so when parents see this and they can hear this and it saved the system, when I use silver diamond fluoride and it costs 1/20th as the cost of doing a filling for Medicaid, people pay attention. And I'll talk about some of the health outcomes and long-term things further downstream. Next. This is not just crazy Johnny talking about this as well. This is from the ADA from 2018. They came out with guidelines on non-restorative techniques. I think right here, the practical implications are very important. It says, although the recommended interventions are often used for caries prevention or in conjunction with the restorative treatment options, these approaches have been shown to be effective in arresting or reversing caries lesions. We should be encouraged to prioritize use of these interventions based on effectiveness, safety, and feasibility. I'm doing exactly what the ADA told me to do based off all the evidence. Next. In 2025, in November, Canberra actually came out that published this in the AGD, the Academy of General Dentistry. This is actually practical implementation. And this actually is a decision tree algorithm that you can use in your practice. And look this article up. You can go next. And I'm not going to go over all this because, again, I'm putting the afterburners on. But you have this for your records, where I have primary tooth, baby tooth, and a permanent tooth, and what you should actually be doing and how you should be treating these different lesions based on the evidence. So why is this important? It allows for standardization. It doesn't allow Dr. A to be conservative and Dr. B to be aggressive. It allows us all to be standardized, and it allows it to be scalable. Next. And right here, again, this is like in Canberra, we talk about the ADA CCS. That's the caries classification system that's based off of ICD-10. Again, we're taking the personality out of the treatment planning, proposed treatment process. Basically, it's a blemish and a black spot in dentistry. In medicine, if you have cancer, you stage it. Well, in dentistry, we stage things as well. You're able to say if a lesion's 1 or a 2 or a 3 or a 4, but we actually have no studies to show the prognosis and different interventions and therapeutics or modalities and knowing whether it's successful. And I understand why we haven't been able to do that in dentistry. It's because we look at the tooth level. And for me to look at a tooth level and I see a kid that has 20 cavities, I have to say the surface level and like the extent. It would take me 20 to 25 minutes to document that. And all of a sudden, so now we don't have any of this, but with AI, that's all changing. And I think in the future, we're going to have, in the next 5 years, I think we're going to start seeing different modalities in the literature with these different stagings and showing with a very precise detail what we should be doing given the size of the lesion. Phew. I know that was a lot, but I'm going fast because of that break. So I think the next slide is a break. Is that correct? Any questions? I know I said a lot very quickly, but I'm trying to like make up for the time I lost with yeah.
And folks can post in the chat or come
Okay.
up.
So you want to keep pressing?
Do we see any questions? Nope.
Keep going, I see. Okay, right on. All right, so the second part of this is really to talk about, this is not the end-all be-all panacea of all the different medicaments. Literally, I have to update this slide every like 3-6 months when I do any sort of presentations. At this point, this is not it. This is not comprehensive. I do just want to like expose you to some different like medicines that exist now and that are coming. So I'm going to talk a little bit more in detail about silver diamine fluoride, so I'll save that. But you have Green Mark. Green Mark is basically strips that you can buy that uses your saliva and it will actually create hydroxyapatite, right? And so you can put that on your teeth that can help remineralize. Fluoride varnish, you all know about fluoride varnish. I won't talk about that. I'm going to talk about glass ionomer cement. You probably hear about nanohydroxyapatite. There is literature that suggests that this is a good medicament, and you really want to be focused on the concentration level of it and the particle size. Those are the two most important variables of knowing whether this is good. That being so, if you have fluoride hesitancy, one of the things that I think we get wrong in the dental profession is we get in the right wrong game. We're not listening to our patient. So instead of us getting like out the gate, if a patient says, hey, I don't like trust fluoride, that's not the time to tell them, hey, you know what, you're wrong. Listen to them, and you know you can get more trust when you start listening to their concerns. And it's, you know, I can't tell you how many people that I that have fluoride hesitancy, and then after, you know, the first visit or the second, they start letting me put fluoride varnish on after the fact. And it's because I don't get in the right wrong game. I'm actually giving them different options and different modalities that they can use, because if all we say is, oh, use fluoride varnish, I don't want to use fluoride varnish, and you say, okay, I can't do anything for you, then like, what good are we? We're better than that, and there's other options out there. So nanohydroxyapatite, one of the downfalls with it is that it is more expensive. And also, I would say if you look at hydroxyapatite, the literature has been in the 60s and the 80s, not very successful because the sizes are too large. So if you really want to go that route, make sure it's nanohydroxyapatite. There's arginine toothpaste. If you don't know what arginine is one of the 20 amino acids. If you're in dentistry, it should be your favorite amino acid. What it does is it actually, so Tom's of Maine, their sensitivity is actually the one that owns so Tom's of Maine is actually owned by Colgate. Colgate has formulations of arginine toothpaste in other countries. They were supposed to push this out last year. To my knowledge, they haven't actually released it yet. However, you can get it through Tom's of Maine. Basically, what arginine does is it actually interacts with the biofilm, and when the biofilm metabolizes this, like of karyogenic bacteria, it produces ammonia, which raises the pH. So we know that when the pH is lowered, 5.5 is Stephan's curve, is when demineralization occurs. This actually raises your pH to above 8. So this is another great option that you can use for your patients if there's fluoride hesitancy. Then the next product is Papa Carry Duo that got released, I think it was last year by Elevate. It's been in Brazil for over 20 years. They're basically using the enzyme from papaya, papain. So if you have meat tenderizer, it's the same thing. But basically, you can put this in a cavitated lesion where there's infection, let it sit for 30, 60 seconds, and within about that minute, it actually pulls out the infected dentin, and you can mechanically remove that soft exposed infected material with a spoon. Or if you're like out in the field and you don't have anything, you can actually use water or a micro brush. I was actually on a missions trip in Eleuthera, and I helped countless kids using this because they were so scared, so afraid, and I was able to do caries removal using this Papa Carry Duo without having to numb them. Blue check is basically it shows activity. So it's actually, back in the day, we had these disclosing tablets, same sort of thing where you can actually paint it on teeth and it's going to actually show you activity level. Because when we look at karyology, activity is actually the most important thing to look at. It's not, and it's hard to be able to, for a very long time, we've not been able to really ascertain, is it active or not? We've known if it's cavitated or not. However, that's a poor descriptor. All the science shows us that, because you can have a cavitated lesion where there's no activity, or you can have a non-cavitated lesion where there is activity. This allows you to see it. Curodont came onto the, is actually from Switzerland. It's known as P11-4 self-assembling peptide. Basically, what this is using your endogenous calcium and phosphorus in your own saliva. You put this peptide on, and it uses your own saliva to actually pull, like where you have a non-cavitated lesion, it actually remineralizes the tooth from the inside out. So think of like a hard-boiled egg where the shell is not cavitated. There's not a hole there, otherwise the yolk would leak out. So it's using this peptide to pull through and actually rebuild from the inside out. Great. And then betadine, I'll talk about that momentarily. Keep going. I'm gonna go fast. Sorry, guys. That really threw me off. That 10-minute break. Silver diamond fluoride. If you haven't heard it, this is the second thing that saved my career. The first thing was getting the pediatric dentistry. The second thing was silver diamond fluoride. Basically, we know that silver is bacteriostatic and bactericidal. So we know that it stops bacteria and then it actually kills bacteria. And so this is different than any sort of therapy that actually really exists because of its substantivity. What it does is when you paint it on teeth, it actually gets incorporated because of the high dose fluoride into the tooth where the lesion is, and then it remains latent, and it actually helps kill the bacteria. And if you get insulted by another karyogenic insult in the future, it frees the ions again and it kills the bacteria again. The rub against silver diamond fluoride is you'll hear that it turns your teeth black. It only turns black where there's a lesion. I can let you know that I've switched with silver diamond fluoride with I don't have black teeth. I've done it over 8 times. However, that being said, you do want to be cautious. You only want to put it in areas that that could potentially turn black. So if you have any concerns that it could turn black, don't use it there. But if you're afraid of it turning black, just because it is biologic and it's smarter than us and it's one of the best caries detection medicines out there. Next. As far as application, the most important thing with application is making it sure it's as dry as possible. And so you may have heard in the literature about using floss. One of my favorite applications of using this is painted in between the teeth interproximally and interdentally. I will use a micro brush, and I basically will use that silver diamond fluoride. You will never see a color change if you get it early enough. But dry, paint it on and allow it to dry for about 30, 60 seconds. That being said, I probably have to update this because there was a study that came out of Hong Kong very recently that says 10 seconds. I need to look at that, but I'm just letting you know the standard is about 60 seconds. Keeping it dry, paint it on. Next. These are just studies to show you we are using it off-label in America, but in Canada and in Japan, it's actually used as a caries arresting medicament. In the United States, it was approved by the FDA as a desensitizer, just so you know. That being said, we know that it is effective at treating cavitated lesions. We know that it's similar to composite resin fillings. We know that it outperforms all modalities besides sealants, right? So I have all these studies here, and there's a whole host of them. When I first started practicing this way, the literature is all I had, and quite frankly, it was so new, there wasn't much in the United States. At this point, there's so much literature that backs up everything that I'm saying that I can say this with like the utmost like conviction and just, I've been validated. Next. Glass ionomer. I just bring up glass ionomer because there's 2 different types of filling materials really that we talk about in dentistry. There's resins and there's glass ionomer. I'm going to let you know our practice has been like 99% glass ionomer from day one. Glass ionomer, even though they're both tooth filling materials, they're remarkably different than resin composites. I actually believe you can do quite a bit of harm with resin composites. You can literally do no harm with glass ionomer. And they're unique among dental materials because they actually chemically bond to the tooth versus a resin composite physical is micromechanical. And there's basically over time, every bond will hydrolyze and it breaks down. And it actually acts as a reservoir for fluoride. So every time you brush with fluoride toothpaste, it charges up right in that where you use that glass ionomer cement, and over time it slowly dispenses that fluoride. So for that reason, we use that like 99% of the time. The 1% of the time we use resin is for trauma and for basically these aesthetic area zones. Next. So the uses, so you can use it for a sealant, which is basically for preventive in the back posterior area where there's grooves where you put this little material over the top of it to prevent cavities from forming there. You can also use it as an atraumatic restorative technique, which I'll talk about momentarily, or you can use it as restorative, like traditional restorative material. Next. So the key features of a glass ionomer cement is that, I'll say the difference between resin and glass ionomer. Resin, you have a tooth, you have to put a layer of glue, you have to put the filling material or resin material over the top. You shine the light shines, like basically pulls towards the light, you end up with a micro gap. And you can see with SEM and electron microscopy, there's actually a micro gap there. And over time, that bond hydrolyzes. So if you wonder why insurance companies will pay for a filling or a sealant every few years, it's because the bacteria actually goes in underneath there and it will compromise it. And so when we talk about definitive treatment, there's nothing definitive, in my opinion, nothing definitive in dentistry except for an extraction, because long enough timeline, everything fails. The difference, and the other thing with a resin is it absolutely has to be bone dry. You know what's not bone dry? A 6-year-old's mouth that's moving around and that's squirming and spitting. So actually with glass ionomer, it's hydrophilic. So it actually bonds and it chemically bonds. And there's actually, you can look with like histology, we call it the zone of fusion, where it actually chemically bonds to the tooth and it becomes one. So literally you can do no harm by putting it on there. And it's very easy. The more, techniques, and I don't have time to go through the technique of how to put it in there. However, because it is hydrophilic and because it chemically bonds, and because it's moisture tolerant, those are like all three really great reasons that really stack the favor for glass ionomer, in my opinion. Next. So you can see these are just step-by-step placement of a glass ionomer. You will notice that a lot of times the glass ionomer talks about an etch. Never use phosphoric etch. That's too strong. The pH is too low. So you're going to want to use a cavity conditioner. The cavity conditioner is actually a polyacrylic acid. The pH is about 6.5. Tastes like orange juice. And what that does is it doesn't decimate the smear layer and it doesn't decimate the whole the substrate. So it allows the chemical bond. If you use a phosphoric acid, you're going to affect the retention. That being said, I always recommend using the polyacrylic acid or the cavity conditioner. You put it on and you put the glass ionomer on top of it. If you want to have much better retention and success rates in the future, one of the most important things that you absolutely have to tell your patients is have a soft diet for 48 to 72 hours. Because it's a chemical cure, it actually gets harder over the days grow long. And if you start loading it too quickly, it will compromise the reaction and you will have broken sealants or restorations. And so you absolutely must adhere to this soft diet. And when I say soft diet, we're talking about applesauce, mashed potatoes, eggs, noodles, things like that. So if it's like little Susie's birthday and she was promised that she's going to go out and have, some chips, I would defer putting glass ionomer on that day because 100% it's not going to last and it's going to break. You want to make sure that you have a better prognosis moving forward. Next. A traumatic restorative technique that was actually pioneered by Jo Franken out in Holland. And basically the concept is doing selective caries removal without any numbing and using a glass ionomer cement over the top of it. And so you're basically, if you have a clean DEJ, dental enamel junction, and you've removed substrate, you can actually have tertiary reparative dentin form without having to remove all of the decay. And so the WHO actually came out in 1998 and said that this should be the first line defense. And so this has been over 20 years. We've been talking about this sort of treatment. And so I'll let you know, that is what we do in our practice is basically ART. This is where I get a little political and, I'm a card carrying member of the ADA. I told you, I'm the president-elect for New Hampshire for the AAPD, but in 2001, there's when the AAPD actually came out and called this IRT, interim therapeutic restorations. And what that is implied in that name is you have to go back. It's not definitive. And I'm going to let you know, we treat these restorations as definitive until proven otherwise. And so we are not saying this is substandard care. We are saying that if you do ART and it doesn't progress, there's no need to go in the second time. Next. This is from the AAPD. I just have this for your reference. We'll keep going in the name of time. Keep next. We'll next on that as well. On how to do it. Betadine. If you haven't heard of betadine, this is probably the greatest kept secret in dentistry. It's a surgical scrub. It's antifungal. It's bacteriostatic and bactericidal. Why do surgeons use it before they go in the operating room? Because it kills bacteria. And so why have you not heard of it? Well, you can't actually monetize it and make a lot of money off of it, right? So I'll let you know there are studies that show that all the way going back from the 70s, if you pair this with high dose fluoride varnish, it actually has higher preventive factor than silver diamond fluoride. I'll say that again. It has a higher preventive factor than silver diamond fluoride. It does not stain teeth. It actually kills. So it is bacteriostatic and it's bactericidal. The downside of it is it does not remineralize. Next. So we actually know that betadine actually will selectively kill karyogenic bacteria. And so this is actually from Tanzer. And I think this article is from the 70s. Tanzer, if you remember, is the one out of University of Rochester, if I believe. And he was the one that said, talked about the maternal transmission of caries. Same individual right here, talking about betadine. And so I actually really got into betadine during COVID because Duke came out and was actually showing that it was effective against COVID-19 when we were not able to do aerosols. They were putting in the air in the. I read the study out from Duke, and they were actually showing that, oh wait, we can do aerosols if we actually use betadine. And I went down this deep dive and started reading all about these things, and I was like, oh my gosh, we've had a solution here all along. So betadine is part of our protocol moving forward. Very, very cheap. Next. So, pairing it with fluoride varnish, we love to do that. We use betadine like our protocol because we want to make sure people are compliant. We like to make it as simple as possible. Once a month, use a drop of it, paint it on teeth. Your teeth will turn orange colored for about 2 minutes and it dissipates. There are studies that have shown that it does not affect your T3, T4 levels, so your thyroid, at that very low doses. There's actually been studies that have shown that it doesn't affect your, like your analysis, any of those sorts of things. The major contraindication with betadine is if you've had IV, IV for like IV, IV treatment, and that's usually associated with cancer. So that would be your only contraindication. To date, to my knowledge, there's actually never been any reported adverse outcome in the mouth. There's been plenty of adverse outcomes reported on your skin, like contact dermatitis. So very, very, very safe. Another misconception with betadine is that if you have shellfish allergies, that will be problematic. That's not true. It's actually the protein in shellfish. So again, if you have a shellfish allergy, iodine is safe. However, to be prudent and be as safe as possible, if anybody who does report that, I always recommend them going to see an allergist. That being said, I'm just letting you know this is what the literature says. So we do use glass ionomer in the first visit. We use betadine. We use silver diamond fluoride. Just don't use silver diamond fluoride at the same time as glass ionomer on the same tooth. So you want to reserve so if you're concerned about stain, say in the anterior, use betadine. It won't stain. If you're not concerned about stain and you have a little bit more effectiveness for like remineralization, use silver diamond fluoride in the back. Wow, I've got 10 minutes. I'm so sorry, Liz. So sorry, Shayla. I'm going next. I think this is like the next. So this is what it looks like when you paint betadine on, just so you know. So this is a 3-year-old that came in. And so the only way that I would have been able to offer restorative treatment on this is to put this kid to sleep and do crowns on them. You do betadine, I can let you know at this point, I'm not concerned about the developing teeth. You can see 8, 9 there. I'll let you know because these are cleansable. Without exception, these almost never progress. Once people get on and the reason this doesn't progress is because we identified the patient was going to bed with juice at night. So once we change that behavior, all of a sudden these don't get worse. And so now it's an aesthetic thing. Well, not, I can do these, there are treatments that I can do if the kid is compliant, and I can do no numbing like crowns and things like that, potentially. But I do want to let you know, just because you can doesn't mean you should. I've actually seen this actually progress, not progress, and all of a sudden we don't have to do anything, and the permanent teeth erupt, and there's no problem. And we've gotten to the root cause of it. And so it's all about patient education. And I haven't said it because I haven't had time to come up for an air of breath. But diet is primacy. If you don't feed the bugs, the food source, the refined carbohydrates cause the acid, it's impossible to get caries. I think the next one's a break, but in the name of brevity, I'm going to keep going. Thank you, guys. So the model. So this was actually, I think this is why I'm here is because we published an article in I think it was February or March in the California Dental Association Journal. And basically we're talking about this model. And so the model, these are the 5 pillars of the model. And this is something that you can implement in whether it's private practice, whether it's the FQHC. You can actually do this in a medical facility. It all works. But basically it's predicated on high volume, minimally invasive. Basically get to the disease as quickly as possible and nuke it, get rid of it. We also believe in it's not just because I have alphabet soup after my name. If we can delegate to anybody within their license and within their scope, they should be treating the disease as at the highest level, because I should only be doing the things only I can do, because then we can actually have more synergy, etc. And I'm going to get through these. So next. I already talked to you about this practice. So basically the concept here is high volume, minimally invasive care. So what this means in practice next is, instead of doing quadrant dentistry, Liz, you can go next. Yep. We're doing, I call it the bundle, which is disease management. A patient comes in and I'm doing disease management. They're getting the glass ionomer, they're getting the silver diamond fluoride, they're getting the betadine, they're getting all the education, they're getting a high dose fluoride toothpaste to go home. They're getting knowledge on how to get the betadine. They can buy, I can give them a swab, swabs for $1 if they want, but they're getting on the protocol. And so instead of me going quadrant dentistry, bring them back for an hour appointment, another hour appointment, another hour appointment, we're doing disease management out the gate. And 80 to 85% of this can actually be delegated, not to by me, but to somebody else. And so I've actually seen kids that have come in, and I don't have time to talk to you about the Hall crown technique, but the Hall crown technique is basically doing stainless steel crowns without any numbing or any drilling. And I've seen kids that have come in from Vermont where they've never seen a dentist, 4-year-old, where I've been able to do all the disease management, 8 crowns without a single shot, without a tear, in a 40-minute appointment. And so that's not like, so that's not, I'm sharing that with you because at one point, we believed we couldn't run a 4-minute mile. I'm letting you know it's possible. And I actually just had a conversation with one of our associates yesterday, Ryan, and he actually just did this for the first time. So now I'm letting you know this would be a kid that I would typically be putting to sleep, and all the like things that we couldn't do. Now we're able to do the bundle and do disease management because SDF takes 1 minute, povidone takes 30 seconds, glass takes 2 to 3 minutes. So what does this look like in practice? Next is that it allows, I talked about the scalability, more access. Next is that you can get more access. So now all of a sudden I don't have to bring a kid back 4 times. Now I'm able to like bring them back 1 time for their abscess tooth that I have to take out, or or just 2 times because I'm doing disease management, half mouth, etc. But really, we only ever bring a kid back twice. Most of the time, if they have to come back, it's 1 time. And now all of a sudden, we only have to see them every 3 to 6 months. And now all of a sudden, once we've gotten them on that protocol, it may be 1 tooth or 2 teeth may become an issue in the future, but for the vast majority of them, because we've treated the disease so far upstream, it doesn't become problematic. Well, you've probably picked up, I'm high energy. And the worst thing that you can do is keep me in the clinic. Like if I don't have anything to do, there's nothing for me to do. So that's one of the reasons we kept opening practices and creating more access. So you can see we've added 11,000 new patients in 2025. I can let you know with the 12 practices that I have in our portfolio right now, we'll probably have about 70,000 patients in the next 2 to 3 years. And it's because we're just doing disease management and there's nothing for me to do. And so all of a sudden I want to, keep helping the people that I can help. That's what it looks like in practice. Next. Sedation, this is cool. Basically, in 2017, this is the first practice we implemented this. You can see that the darker line is where we first started using silver diamond fluoride. And you can see that we were actually doing sedation. And I didn't have time to upload this, but yesterday I've shown that we've reduced our nitrous sedation by 97% since we started. And so now this is what it looks like. We're doing silver diamond fluoride. We're still doing sedation, but I used to be buying, a nitrous tank every couple of days because I was just doing quad and dentistry on kids. Now it's not necessary anymore. Next. This is the first practice, right? Most GP, like the average general dentist, has 1,800 active patients in their practice. Well, once we started adopting disease management, we actually grew the practice by over 300%, but reduced doctor time by 78%. So we've created significantly more access while reducing my time. So what does that mean? Well, if you took our data and everyone says that you need more dentists, I'm going to let you know, if you take our math, you actually have too many dentists now. We're just using it's a mismanagement of human resources. And so when we're talking, if we actually want to get to the bottom of this, this is how you do it. Next. So again, you can see the growth, and again, just create more access. So 900%, 45%, 30%, 30%, 50%, 50%. This is what it looks like when you actually do disease management and minimally invasive dentistry. Next. The important thing about this is I wanted to show the broken appointment percentage, because one of the things that you hear is people don't show up. I'm 60% Medicaid. Look at the broken appointment percentages. And I can let you know the highest one is Portland. And that's because that has unique dynamics where I'm dealing with a very large Somali population with 30 different languages. 6 months ago, we were at 30%. We got it down to 8%. But as an aggregate, I'm at 3.3% broken appointment over 35,000 patients. And so I'm letting you know, people know where your dental clinic is. People know where McDonald's is. People know where Walmart is. People vote with their feet. If they're not showing up, why are they? Do they perceive value? I think we got to look ourselves in the mirror and say, like, what are we offering? And why are they not showing up? It's easy to blame them, but I'm going to say we got to look at ourselves and have an honest conversation. So that's why I wanted to show you that slide, because this is true. Next. Comprehensive care, so another outcome. Basically, composite restorations in the first practice we did this in, 43% of our patients had a composite, like traditional filling. Fast forward 10 years, it's less than 4%. Less than 4% of our patients now have extractions or traditional fillings. However, over you can see, it's like over 50% have SDF. So again, I think one of the things that people have accused me of is not doing comprehensive care and just doing monitored neglect. That is so far from the case. I am doing extractions. That's actually the only thing I do really is extractions and crowns, because I can't delegate them. But I'm doing it at a much less frequent clip. We did 6,000 crowns last year. So we're still doing comprehensive care. We just have to do it at a far less clip because there's nothing for me to do because we've managed the disease. That's what true outcomes look like. Next. I'm sorry, guys. I got 3 minutes. Parents, I'm just showing you this is about agency, and this is where people vote with their feet. Basically, parents are saying we want something different than just watch it or putting them to sleep. And your patients, if you have adult patients, where you're saying this is the only thing we can do better than them. And we need to start telling them about all the different options. And maybe sometimes they're gonna like not want to do what we recommend. That's okay. And I'll say, like, if it goes and progresses, then you can tell, and then you can intervene and do the thing you wanted. But we need to start listening to our patients. Next. I talked about team roles already. Next. Just I have this in here because this is Massachusetts. This is the scope of care, and most people don't read the practice acts. This is Massachusetts under here, and the different types of supervisions. We actually have hygienists that can do stainless steel crowns in Massachusetts. Most people don't even know that. If I'm in the clinic, they can do it, but nobody lets them do it. Well, why don't we let them do it? I say let the ponies run. Like, let everyone do the thing. Like, let's get this disease under control. Next. This is model work. So this is the paper that that I was referencing earlier. And so basically it does work. This is what we published. Next. This is the last article that we published. This was in Frontiers. This was basically over 7 years, over a sample size of over almost 9,000 kids using medicine first. 83% of the kids didn't require anything else besides medicine first. In 17% of the cases, we had to escalate. And when I say escalate, we're talking about doing a filling or crown, an extraction. However, in those 17% of the time, it was almost a year and a half later. Well, there's a huge difference from a 3.5-year-old to a 5-year-old. So all of a sudden, can you imagine, like, if you can actually do like treatment in the clinic now? So of that close to 9,000 kids that we saw in this sample size, only 31 of them required general anesthesia. Again, we offer the full complement of like processes. However, I'm going to let you know that we're able to reduce things at a much greater clip if you do disease management. Man, I'm at 1 minute. I think that this is the last slide, really. I apologize. Thank you for your patience. I know I gave a lot of information. I'm here all as long as you want. So I'll leave it at that.
Well, thank you, Johnny. I'm going to get us through some housekeeping pieces to make sure everyone has their next steps for CEU. If folks have questions, I would invite you to post them in the chat. Johnny, also, if you're willing to post in the chat, we have a wonderful intersection of dental public health here. We have clinicians across different roles. We have many advocates. We have public health folks working at the administrative level. So understanding your models and your papers and the different options for care, we'd love for you to share what action you want folks to take. I know that there's several people here who are going to Open Hill Day next week. There are people here who go to many different oral health hill days throughout the year. What action do you want folks to take?
Do
If you
it.
want to share that in the
I'm
chat, that would be great.
I'm saying I am just saying do it. So like when I first started this practice, I was waiting for the board of dental examiners to arrest me. I didn't know all the academics I know now. I was just on my own island, and I was like, you know what? I'm gonna like if I get charged, I'm gonna die on this hill because people. I think we're like neglecting people and we're hurting people. We're so far past that point now. That I would actually argue this is the standard of care. And I'll also share this. Like I've had like very frank conversations with the ADA about updating all their guidelines, and they're actually reaching like, as a Canberra board member, they actually want our input, and they actually say, okay, like you're absolutely right. This is what cardiology is saying. So the action is start using silver diamond fluoride, start using betadine, start using glass ionomer, because like this is not hard. This is not like this. I promise you, this is where like the ego kicks in. I went to 11 years post high school to do things that I can train someone within 90 days to do 80, 85% of it. That's a huge ego check. And I'm going to be straight up with you. But if we ultimately want to get this disease under control, then we need to like look at that and say, okay, we need to empower people to be able to do the thing and get the disease under control. So more than anything, like I would just encourage you to do it. You literally can do no harm other than doing silver diamond fluoride in the anterior. I would like, again, I don't do that. I've used gallons of silver diamond fluoride. I don't really use it in the anterior because of the aesthetic concern, but everything else, start using it. Use betadine and use everything. So that's the action, is do it. And if you need to know how to do it, like email me or text me or whatever.
Fantastic. Well, thank you. I'm sure everyone has the housekeeping pieces. So if you are wanting CEU for today's session, Sheila is posting that link in the chat. That's available on our phone. We also have an evaluation tied to that. So if you don't want CEU but would like to share your thoughts about this session, we invite that. We're always looking for upgrades. Again, we will be posting the recording, the full slide deck. So if you want to go back and look through those details again, I know we were going fast and furious. Thank you for your patience. Those will be available for you. We will follow up via email with those as well. We will be having our next oral health seminar, our next rooted seminar in July. So mark your calendars and keep an eye out for that. We also want to share if you're interested in looking at things at the federal level or advocacy training about how health agencies intersect with real world models and programming like this. Our Federal Service Immersion Program is open now, and you can apply. Sheila's also sharing the link to that in the chat. I'm sharing a real quick screenshot here of when you go get your CEUs. If you have not used our Academy before, you will set up a username and a password. It is free to do so, and you will have access to not only this session, but other recordings, etc. You will click here and you will scroll down to the session to find your specific CEU request form for this session. Thank you again, everyone. I know we had a few technical difficulties. We're a couple minutes over. Thank you so much for your patience. I hope you join me. And a big thank you to Johnny for his time and knowledge today. I'm looking forward to seeing you all on our next Rooted Seminar series in July. Take care, everyone.